Hello, everybody. Thank you for tuning into this interview with the Journal of Immunotherapy and Precision Oncology. I'm honored to be introducing Dr. Nader today, and we will be talking about his publication in our journal, Audiovestibular Toxicity Secondary to Immunotherapy, a case series and literature review. Dr. Nader, thank you for joining us, and if you could please introduce yourself to our listeners.
Thank you very much for having me. So my name is Marc Nader, and I'm a neurologist working at the MD Anderson Cancer Center.
Perfect. Thank you again for joining us for this interview. And we had a set of questions we wanted to ask you about this paper that you published with us. And first and foremost, we kind of wanted to know what prompted you to study or to write the study of audiovestibular toxicity.
So as I mentioned, I work in a cancer center. So quite a few patients I see are patients who present with otologic symptoms, either from their cancers or from their cancer treatments. So over the past few years, we have seen an increased adoption of immunotherapy, especially immune checkpoint inhibitors and T-cell therapy. What we've seen is patients who present with a particular set of otologic symptoms, and we wanted to report these symptoms. We attributed these symptoms to immune-related adverse events affecting the inner ear. And then when we look at the medical literature, there's little written on these patients. So only a few case reports, a limited case series. And so we wanted to share our experience by writing this case series. So to describe how these patients presented, what their medical management was, and also what kind of otologic outcomes we obtained.
Great. And can you kind of give us an overview of the findings that you published?
Sure. So we included 4 patients who presented with audiovestibular symptoms following immunotherapy. 3 of them had metastatic melanoma, and 1 of them had metastatic renal cell cancer. All these patients received immune checkpoint inhibitors, and more than 1, so either 2 or more, and 1 of them also had T-cell therapy. So the main symptom, so all of them presented with hearing loss and tinnitus, and 3 of them presented with vertigo and imbalance in addition to the hearing loss. So now, what's interesting is the characteristics of the hearing loss. If we take a step back and we discuss very briefly ototoxicity from platinum-based chemotherapy, so for cisplatin, for example, the hearing loss mostly affects the high frequencies, is progressive, and affects hearing understanding or speech understanding in a more limited number of patients. And it tends to be irreversible. But for our patients, what we've noticed is they present with bilateral sudden hearing loss, and the hearing loss affected most of the speech frequencies, and also their word understanding abilities was quite diminished. So here we see a difference compared to the toxicity from traditional chemotherapies.
Very interesting.
Yeah, and then all these patients received steroids, either systemically, locally through intratympanic injections, or both. And what's interesting is that most of them, so 3 out of the 4 patients, responded favorably to the steroids and had significant improvements in their hearing. Then we had 1 patient who presented a bit differently, who had recurrent episodes of sudden bilateral hearing loss, even after cessation of immunotherapy. But thankfully for this patient, each time we gave him steroids, the hearing went back to baseline. And after 4 episodes of recurrent episodes of hearing loss, we put him on infliximab, which is an immunosuppressive agent, and his hearing stabilized.
That's a very interesting presentation. So what would you advise to the listeners and to providers who are taking care of patients getting immunotherapy? How would you advise them to approach the diagnosis and the management of potential immunotherapy-related audiovestibular toxicity?
Yeah, this is a great question. So from our clinical experience, from the case reports, it seems that these audiovestibular adverse events are quite rare. But still, we have to keep a high level of suspicion for these patients, especially since we see that they tend to respond to treatment. And so when a patient presents with new onset hearing loss or tinnitus or vertigo, or if their hearing is worsening over time, then this should prompt referral to audiology and otolaryngology quite quickly. So right now, there are no guidelines recommending auditory testing before the start of immunotherapy. But once patients present with these symptoms, then we recommend audiogram testing to really try to objectively see what the level of hearing is. For patients who present with vertigo or imbalance, we can also offer vestibular testing in the form of video nystagmography, or in short, VNG. And so the VNG will look at the peripheral function of the vestibular system. We can quantify that function. And also there's a way to determine if there is central adaptation or not. What we have to keep in mind is most of these patients on immunotherapy have advanced cancers or metastatic cancers. So also what we have to make sure is that they don't have metastatic disease involving the temporal bones, or they don't have leptomeningeal disease. So oftentimes we'll offer MRI of the brain, and we may also offer a spinal tap to make sure there's no leptomeningeal disease.
Interesting.
And so once we make the diagnosis of an immune-related adverse event affecting the inner ears, then we can think of treatment. So right now, there are no guidelines on what is the optimal treatment for these patients. So what we do is we treat them similar to patients who have sudden hearing loss or patients who have autoimmune inner ear disease. So for these patients, and as we described in our case series, steroids remain the mainstay of treatment. And we can offer the steroids either through systemic administration, orally or IV, or for those patients who cannot tolerate systemic steroids, we can offer intratympanic injections.
Great.
And then one last point is, if we extrapolate data from patients with sudden hearing loss, it seems that the earlier we treat patients, the better it is, and probably we would have a better, hearing improvement.
Very great, and that's why it's so important for people to be aware of this then, and
correct.
Think about it.
Yeah.
Excellent, excellent. And then Dr. Nader, I guess the final question we'd have is, what unanswered questions you think remain that you would hope that we get answers for in the future regarding immunotherapy-related audiovestibular toxicity?
Yeah, well, there are a few questions that we still need to answer. The first one is, what is the incidence of these adverse events? So from clinical experience, as I mentioned, it seems that these events are quite rare, but the data we have is based either on clinical experience or limited reports and case series. So right now, what we are undertaking at MD Anderson is to do a broader retrospective review, looking at a large number of patients on immunotherapy and see which one of them had changes in their hearing and hearing loss on audiogram testing. And the other question is hearing loss always in that sudden presentation, or do we have also patients presenting with a more progressive hearing loss similar to the toxicity from cisplatin chemotherapy? Another question relates to the underlying pathophysiology. So right now, we're not sure exactly why they have hearing loss. We have some theories. One of them is it may be a form of neurotoxicity, maybe a form of inflammation of the cochlear nerve. But there's another theory that's also very interesting, and maybe some cells inside the inner ear may be the target of the patient's own T cells. So inside the inner ear, we have the stria vascularis, which is important for the ion gradient formation and the endocochlear potential. And in the stria vascularis, we have cells that look like melanocytes, and they're called melanocyte-like cells. And in some autoimmune inner ear diseases, these cells are involved. So it's very logical that these cells could be the target of the patient's own T cells once they start immunotherapy. And I would say the other question that we need to answer is with regards to optimal treatment management, the optimal management strategies for these patients. So one related to the agent. So right now we're using steroids, but are there other agents that we can use for these patients? And also the timing. Is it like sudden hearing loss where we have just a few weeks, a very limited time frame, or would these patients respond to steroids even several weeks or several months down the lane?
And you mentioned the one patient who had the repeated episodes and responded to infliximab.
Yeah, and it's interesting because this patient, we stopped immunotherapy, and these episodes recurred even a few months after we had stopped immunotherapy and still responded to the steroids even after several months. And this brings another question, whether we need to stop immunotherapy for these patients or not. So interestingly, when we look at the case reports and the case series that were published, it seems that when they have these kind of immune-related adverse events, actually their clinical outcome from their cancer treatment is actually better. So maybe it's an early sign that they're responding to the immunotherapy.
That makes sense. Yeah. Very interesting. Very interesting. Well, thank you, Dr. Nader, for first of all doing this important research and for bringing these findings to people's attention and publishing them in our journal. We appreciate it, and thank you again for taking the time to interview with us. And I hope that people can go to they can go to the journal and they can find this article published in our journal. And thank you again, Dr. Nader. It's great.
Well, thank you very much for your time and for your interest in this subject.
Absolutely.